So, good night, everyone. Thank you, everyone, to join us today in this webinar. I will discuss some updates on the ATA guidelines. Here we will focus specifically on molecular testing, and I hope you all enjoy this webinar. I will close here my picture to facilitate. So just before we start, some quick messages. Feel free to take pictures or prints from this screen or to record. If you want to post, please use our Instagram here. This webinar will be available for the ones that were registered on our YouTube. You will receive that in your email when it's available. If you are here, you agree that this webinar can be recorded, right? And today is December 3rd. And questions are very, very welcome. Please bring your questions in your chat, and I will be really happy to answer all of them in the end of this webinar. I can see here many friends, many known people. Thank you for all of you to be here. So welcome. If you want to offer better care for your patient, to keep up to date about thyroid nodules care, and of course, to save valuable resource for the healthcare system. So welcome everyone. Just a quick agenda. I will start discussing the patient journey background of the molecular testing. So to understand the types of tests that we have available in each step of this patient journey. Then we'll jump straight on the guidelines. We focus on the molecular testing. We will not discuss the other updates in the guidelines. And then we will discuss the availability of the tests in your country and goes directly to questions and answers. So nice to meet you. I'm Marco Santos. I'm a scientist by background. I have a PhD in molecular biology by University of Campinas here in Brazil, and also from Clinic University from Cologne in Germany. I'm also a researcher at AC Camargo Cancer Hospital, the largest cancer hospital here in Latin America, and chief scientist and founder of Oncos. And that's why I have some conflict of interest to disclose here. But it's important also to understand that this is not an official webinar from ATA. I am myself not part of the ATA team, and all the content that you see here, they reflect my personal interpretation as a specialized scientist in the field. Okay, so who we are, Oncos, that's the company that offers some of the molecular tests that we'll discuss here today. We are a global thyroid molecular tests lab. We do not do anything else than thyroid molecular testing, right? This is the only thing that we do. We have our central lab in São Paulo state in Brazil, and we also have a business office in Barcelona. But we have already performed more than 8,000 thyroid tests in more than 30 countries. So we have partners, we have patients literally in all the continents, and we'll discuss that more in the end. We are crazy for quality, so we are accredited by College of American Pathologists. This is the main quality seal that we have in the world. And we are now pursuing other very important accreditation and certifications for our lab. So, okay, let's start with this patient journey. It's a very important slide to understand all the coming slides that we'll discuss. And it's important also to understand that now the ATA guidelines has two guidelines. So in 2015, nodules and cancer were in the same document, in the same guideline. And now it was split in two different documents. One that it's not yet published. We are waiting. They said that it will be published by the end of this year, but it's not yet published. So what I will bring here are some drafts that I got it during the meeting that they have in Arizona this year. And the other part is the guideline that has already been published. What's the difference? One of the guidelines will treat specifically of nodules, and nodules, they are considering what's classified between Bethesda 1 and 5. And this guideline that has already been published, it's only about differentiated thyroid carcinoma. It doesn't include pediatric patients. It doesn't include medullary carcinoma. It doesn't include anaplastic carcinoma, just differentiated in adults, right? And what they are considering cancer, patients that has a Bethesda 6, or patients that has, even in the other Bethesdas, BRAF or a HET mutation, okay? So in this journey of the patient, we always start, as you all know, with the ultrasound. Then the suspected nodules goes to the FNA, and the ones that are suspected undergo the surgery. Then we have the radioiodine treatment. And for just very few patients, we will think about systemic therapy, right? And why this is important? Because the guidelines are split among here. When we say about nodules, we are discussing the nodules in the ultrasound, because the first guideline that it's to be published, it will also bring new ultrasound guidelines. And they also include, as I said, Bethesda 1 to 5. So in this step of the journey, you have in the first guideline that I showed there that it's not yet published. And when you already have a patient with a cancer diagnostic, which in the FNA, a Bethesda 6, in the surgery, the histopathology showing cancer, or in this end of this journey, that patients that are resistant to iodine, or the patients that are advanced cancers, they are also closed by the guideline that has already been published. So what does that mean in terms of molecular tests? We have 3 different types of molecular tests that are that has clinical utility in this journey. The first type is the most widely used molecular test type of molecular test, which is for diagnostic, right? So those are indicated for Bethesda 3 and 4, which are the indeterminates, right? For our colleagues in Italy, it's usually the tier 3A or 3F, and tier 3, and for our colleagues from UK, also another system, but they all have this same correspondence here. We also have the prognostic tests that are for Bethesda 6 or for cancers that are diagnosed, which is tests that will predict the likelihood of those nodules to be more or less aggressive. And finally, we have the tests that are with intent of therapeutic tests that will help us on selecting target therapy for the patients that are advanced, right? So we will discuss today those 3 types of tests in this patient journey. So I will start with the diagnostic tests, which again are the most widely used and the most known tests available worldwide. So let's talk about indeterminate thyroid nodules. And here, you will hear during this presentation, I will talk about the risk of malignancy, the RUM. It's a very a term that will have very common during this patient journey, and we'll talk a lot about it. Why? When you look on the thyroids or when you look on the Bethesda system, all of them are already based on risk of malignancy, right? So all the tiers, all the classes that we have in both systems, they are based on risk of malignancy. So any type of clinical decisions here are based on risk of malignancy. So this is the base of taking decisions. So for example, when we have a Bethesda 2, although we call them benign nodules, the risk of malignancy of those nodules is between 2 to 7%. It's not 100% sure that that nodule is truly benign. But this risk of malignancy is too low. So once it's too low, it's accepted that we can follow that patient, in the majority of the cases, of course, without surgery. On the other hand, when we have a Bethesda 5 or a Bethesda 6, why those patients undergo surgery? Because the risk of malignancy is really high. Again, Bethesda 6 we call as malignant, but it's not 100% of the cases that are malignant. We have some residual number of false positives here. But again, the patient will benefit from that. The problem, as we saw, Bethesda 3 or 4, which has a risk of malignancy that it's not low, but it's not high. So here we don't know exactly what to do with those nodules. So we need to find any type of technique that will reclassify those nodules. If it's reclassified to something close to a Bethesda 2, we can follow the same decisions. Or we need a technique that will take those nodules out of the zone to something that has a high risk of malignancy, because with that we can do the surgery. So that's the idea on why the risk of malignancy matters a lot here. So when you have a Bethesda 3 and 4, which are the tools that you have to reclassify that nodule? You have the clinical data, you have the cytology data, and you have the ultrasound data. They are really important. And for many cases, you can reclassify them and say, okay, this do not seem to be a malignant nodule, or this is a very suspicious nodule, and you can finish investigation. But on the majority of the cases where that is still indeterminate, is still not in a big or in a low risk of malignancy, here is when you need to use a molecular test. So it's important to understand molecular testing is a complement of the nodule investigation. It's not something that you should use alone, because when you have this puzzle complete, then you can enable a more informed clinical decision, right? So again, remember that we have these guidelines splitted, and we will start discussing first the guideline that treat regarding the nodules, right? That is the 1 to 5. But again, what I will show here are drafts, are pictures that I took from the meeting that was in Arizona. There was not discussed about Bethesda 1, was not discussed about Bethesda 5. And for Bethesda 2, we don't have an indication. So here, our discussion, I will include only the Bethesda 3 and the Bethesda 4 nodules, okay? So it's all my own pictures. So here I bring a comparison. On the left, we have what the guidelines say on 2015, and on the right, 10 years later, what the new guidelines will bring for us. So when we look the difference, both guidelines for Bethesda 3 kept the suggestion to do follow-up with ultrasound, repeat the FNA, to undergo surgery on certain situations, and also to perform the molecular test. All of them are options for the patients, together or in separate. But what we have new here that was not in the previous guideline, they included the second opinion of the cytology. So if you prefer, you can send the slides for another pathologist for a second opinion. It's also an option here. For Bethesda 4, when we compare, again, in the left 2015, in the right 2025, what was recommended before surgery in certain cases or molecular testing, now it's also included the second opinion of the cytology, and it's not recommended follow-up with ultrasound or to repeat the FNA. But you can see here that in terms of the conditional evidence, molecular test has the higher level of evidence here on Bethesda 4. So another thing that they bring are the molecular tests that are available in the US, right? And they choose to include in this table tests that has at least 3 of these 4 topics here, right? So as you might know, Afirma, Thyroid, Thyramir, they were included here. And we have other 2 tests that are not focused in the US and they're not being available in the US that were not included here. But they are available in the world. We have the IDELA thyroid print test, which currently, by today, we have no validation studies published, neither retrospective nor prospective. We are waiting for the results. And the mirror type full, where we have studies prospective, multi-center with blinded cytology review and histology, and real-world evidence. So currently, for the tests that are commercially available with evidence, the mirror type full is the most prescribed molecular test outside the US, of course. So we'll discuss a little bit about the mirror type full test. So this is one of our evidence. This is a prospective, real-world, and multi-center study that was published on the Lancet Discovery Science Journal. In this paper, we followed 435 patients that paid for the test, and they agreed to be followed. We followed them up to 2 years to see what happened in the real world from 128 different sites. What we saw is 91% of the patients with a positive result undergoes the surgery, and 93% of the patients with a negative result avoided the surgery during the follow-up period. So showing that the test can be used even for a rule-in and also for a rule-out reasons. And as the major finding, we avoided 75% of surgeries that would be unnecessary in the end. From the diagnostic performance studies that we have 2 main studies. We have this first study that was published on the Thyroid Journal. We have another study that's up to be published very soon. It's a larger study with 510 patients, all of them with Bethesda 3 and 4, for 14 sites. And on both, we archived very similar results, right? Between 96 to 80% of negative predictive value and 76% of positive predictive value. And here, for the ones that are not very familiar with those terms, just a quick explanation here. When we are discussing predictive values, what does they mean? They are the chance, they are the probability of something happening. So when I say 96% of a negative predictive value, it means that if you have a result that it's negative, it has the probability to be benign is between 96 to 80%. On the other side, when I say, okay, 76% of positive predictive value, it means that if you have a positive result, the probability of being really a cancer is 76%. Right? So it's important to understand because it drives all the decisions here. Remember that I said risk of malignancy is central here. When you have a Bethesda 3 and 4 and you put a molecular test here, in the case of negative, the negative predictive value that I told you, 96 to 80%. In terms of risk of malignancy, we have here a residual risk of 2 to 4%, which is now, in terms of risk of malignancy, a Bethesda 2. So what should be your decision here? The same if you have a Bethesda 2 in front of you, right? In terms of risk of malignancy, this nodule has been reclassified here. That could be even the surgery, right? But we are discussing risk of malignancy. And in the positive, the idea is the same. 76% means 76% risk of malignancy, which is very similar to a Bethesda 5 or a Bethesda 6, which means a very high risk of malignancy. And then this patient usually will be treated with surgery. So the risk of malignancy on the positive starts at 76%, and we will see why it could be higher in the coming slides. A very important thing from the MIR type full is that we don't need the patient to do a new FNA, to do a dedicated FNA, right? You don't need to recruit the patient, you don't need to puncture him again. The same slides that were prepared by the pathologist, the same slides that the pathologist classified the nodule as a Bethesda 3 or a Bethesda 4, those are the slides. This is the material that we need to do the test. If they were prepared up to 5 years ago, they are good to be used. Any type of staining, any type of fixation method, the pathologists don't need to do any special protocol, any special preparation. They are good to be used if they have enough cells, which are 60 cells. 6 groups of 10 cells, with the same threshold to have a Bethesda. With less than 60 cells, you have a Bethesda 1, right? So if you have a Bethesda 3 or 4, it means that you have enough cells for MIR type full molecular testing. So this diagnostic test look to microRNA expression and DNA mutations. So 2 types of different molecules. We look mainly to the BRAF, TERT gene, and RET gene when you have a medullary cancer. So what's important to understand? The MIR type full, we has 2 components in the same test. The first is the diagnostic component, which is the one that we are discussing here, that will answer this question. Is this nodule more likely to be benign or cancer? So with that information, we will decide between follow-up or surgery. But we also have in the same test for all the patients that are tested, the prognostic markers. So those are here to try to answer this question. Is this nodule potentially aggressive? Because if we find some genes that could predict more aggressiveness, probably the plan of this surgery, the surgery of this patient, or the follow-up, or even the classification of the nodule will change. So we put in the same test both components. So with that said, I will enter now in the other type of tests, which are the prognostic tests that can be used pre-surgery or post-surgery, right? So remember, in this journey here, now we are discussing the prognostic tests. But it's important also to understand that you can find prognostic tests that are offered alone, just with prognostic markers, or you can find some tests like the MIR-type full that you have both components in the same test, diagnostic and prognostic in the same one. And why it's important, we will see now to have both. So now we are discussing the other guideline that has already been published, right? Because we jumped to cancer. So this is the guideline that has been published. I'm sure that all of you have seen that. And we have here on the recommendation number 10 regarding pre-surgery. So what is the recommendation? So genomic evaluation of confirmed BPC prior to surgery is not recommended routinely, which means we will not ask this type of test for all the patients. But however, if this genomic profile is known or performed, it may be considered to the context of clinicals, cytopathological, and to inform extent of surgery. What does that mean? It's not recommended for everyone, but if you have that, it's a very good data. It's a very informative data. So that's why when you have a diagnostic test that also brings prognostic markers, you can have both, so you can take better clinical decisions, right? And on post-surgery, it's exactly the same idea on recommendation 28. So molecular profiling after the surgery is not recommended routinely. However, if you know that, if you have that data, they can be used to estimate the risk of recurrence. So again, if you have a test that could bring that, it will be better for you and for the patient, but it's not recommended for everyone. So on the recommendation 10, they bring a lot of discussion regarding which markers, etc. Here, I just bring the main part, which are the markers that really matters in this situation. First, the BRAF and TERT, when they are together, when they are mutated in the same sample. This is the worst genetic profile that we have in the literature for the patients. We will see the prognostic implications of that in the coming slides. Regarding when we have BRAF V600 mutations, isolate just that mutation. It's not yet clear if this is a prognostic marker or not. We have good studies for both sides, but what's been shown in the literature is that it's important to understand the allelic frequency of the BRAF, which means how many cells of that nodule are mutated. If you have just a few cells that are mutated, maybe it's not aggressive. If you have a lot of cells from the same tumor that has the mutation, it has a more aggressive behavior. So also important to look to a test that brings this type of information. So just to show you here some examples for BRAF and TERT, this is a paper from 2014 on JCO, and the BRAF and TERT mutated patients is this red line here. As you can see, 100% of the patients with BRAF and TERT, they have recurred during the follow-up time. So it's a very aggressive pair of mutations. This JAM oncology, they look in terms of mortality. So BRAF in isolate, 4 times more chance of mortality, TERT 8 times more, and when you have BRAF and TERT, 37 times more chance of mortality. So this information should be considered to plan this patient treatment, this patient surgery, this patient follow-up. You know that it's a patient with a very, very high chance of many different prognostic outcomes. We saw that this is a presentation from our group in the International Thyroid Congress that was held this year. So we saw that this allelic frequency of the BRAF is correlated with the ATA recurrence risk, with presence of lymph node metastasis, and also with extrathyroidal invasion. So the more you have of cells mutated in the tumor, the higher is the risk of those characteristics here. And the other guidelines like ETA and also NCCN, they are already also discussing the importance of those mutations. And the other component that it's also discussed on the recommendation 10 are the expression of microRNAs that may be associated with increased risk of local regional disease, right? So having microRNAs is also important in your panel. I will start very briefly discussing about the miR-146b, which is the most studied microRNA by far in thyroid cancer. This JSAN paper showed a very interesting result. So when we look to disease-free survival rate, you can see here the patients with low expression has a very big difference of the patient that has a high expression of this microRNA. And what's really interesting is that when you look to the status of the BRAF, without the mutations and with the mutations, there is no difference. So if you have a panel that looks just to one or just to a few markers, that doesn't matter. You will not have the whole scene, you will not have the whole picture of that patient. So that's important to have panels or tests that brings the markers that matters. And our group will also see the same results. We also presented in the ITC this year. The higher is the expression of this microRNA, the higher is the chance to have lymph node metastasis. So it ranges from 90% to something around 75% when you have a higher expression. So this patient deserves at least a very good cervical ultrasound to check about lymph node metastasis, especially 90–80% of the times in the central neck, right? So again, the MIR type full has both of those components, not only a diagnostic test, but also a prognostic test. And which are the markers that we have on the prognostic component? We have, as I show you, the microRNA 146b. We have both mutations, BRAF, and 2 mutations of the third gene. And we also have this microRNA 375, which is a very good marker for medullary carcinoma. So if medullary carcinoma was not identified on the blood, that usually is not requested. If in the cytologist it was not clear, here on the molecular test is where we will get that information. So we will report not only if this is a positive case, if this is a malignant nodule, but also we say, okay, this is a medullary cancer. And that changes everything in the patient treatment, surgery, investigation, and etc. So it's a very, very big impact for those patients. And finally, let's discuss about the third type of tests, which is for target therapy selection. Just remembering here in our journey where it's positioned here for those few cases that are advanced and will need systemic therapy. Again, look into both guidelines. We are discussing the second guideline here that has already been published. So it's exactly the same guideline that covers that. And the idea here is exactly the idea of personalized medicine, right? So instead of giving for all the patients the same treatment, when a patient has one type of target, we give one type of therapy. Patients that has another type of targets, we give another type of therapies. And for the patients that don't have any targets, they will receive conventional therapy. So you can personalize this a lot. So recommendation 61, it brings that biomarker testing to identify actionable drivers should be performed prior to initiating the systemic therapy. It should be performed. It's a very strong recommendation for those patients because we have really, really good drugs related to those drivers, to those genes. Just remembering, they also recommend that it needs to be performed in a certified lab. And it's very important to choose a panel that looks not only to the DNA, but also to the RNA. Because some markers, the way that we will identify them on the samples is just on the RNA. We cannot identify them on the DNA. So we have a lot of panels that has only DNA. Be sure that your panel has also RNA investigation. Recommendation 6.7 bring the importance of testing for TRK fusions, because we have a drug for patients that has TRK fusions. And again, fusions means RNA. Recommendation 68, the need of testing RET fusions. As you can see here, RNA, right? And again, these guidelines are for differentiated thyroid carcinoma. I'm focused on that because we also have a drug for RET that it's for medullary cancer, but it's not covered in this guideline, right? Recommendation 69 talks about the importance of ALK fusions for RNA. We have a lot of different drugs that are targeted to ALK fusions. They are more studied in lung, they're more studied in other types of cancer, but they have really good results on thyroid patients. And the last recommendation, the number 70, are for the BRAF V600. If you decide to use it as a first-line therapy or not, depending if the patient are not good candidates for levantinib, or if they have progressed or do not tolerate the first line, you can think on the BRAF positive ones. And very important, it's not any mutation on the BRAF genes. The other ones that I show you is any fusion with those genes. Here is BRAF mutated in this codon that we call the V600E codon of the gene. It's important to highlight that. And what about those patients that don't have any mutations that are actionable? So here we have two types of drugs, multi-kinase drugs that you might be aware, levantinib or sorafenib. But in most cases, levantinib is a preferred first line, due to the side effects of both drugs. So again, remembering this patient journey, the types of molecular tests that you have, when they are indicated, and which guideline you should refer if you are discussing nodules or if you are discussing cancer. And what's our aim here with the MIR-type test is to removing barriers. I know that outside the US, all of us has frustrations regarding costs, availability, how to request that, how to interpret that. Our idea here is to remove those barriers. When we talk about costs, we know that the American tests has prohibitive prices for the majority of the countries. The MIR-type full is a much more affordable test. Even when we look to some studies, for example, the UK, they showed that to be a cost-effective molecular test in their health system, it should cost maximum 1,200 pounds. This other paper recently published from Asia population, $1,031. So you see that the what is cost effective is very lower than the American tests. And how can you order the MiriType full in your country, right? So literally anywhere in the world, wherever you are. As I said, we have partners in many countries, in many different countries, in all the continents. But if we don't have a local partner in your country, we can deal directly with you or with your patient, right? We organize all the logistics, we organize all the payments, and we are able to bring samples from those places also. It's very simple. We are a global partner of DHL and other logistic companies. We just send a courier from DHL directly in your office, in your hospital. They pick up the samples and they bring it to our lab to be tested, right? So really, really easy. We have a form online. You just fill that and we deal with everything. How you request, you just email to international@miritype.com and we will contact you to give all the information that you need, and discuss about the best logistic way and the best payment schedule. For the hospitals that we have partnerships, they pay monthly. If it's directly with the patient, we can provide online links, so it's really, really easy. Another thing that is important for you, please save this contact. It's the specialized channel for physicians that we have. So here we can support you on any need. You can have technical and scientific discussions. You can discuss a case with us. We can help you on interpreting the reports and also provide you materials and give you practical answers of all of your questions. So thank you, everyone. If you have any questions, I will be really happy to answer all of those if I know the answer. And here, just one last thing. We developed from those guidelines that has already been published, this free online calculator to estimate the risk of recurrence, right? So it's free. You don't need to put any type of data from your patient. You just put the sample and the nodule characteristics. So it's an easier way to help you on this estimated risk. Again, thank you very much and happy to answer all the questions. Let me stop sharing my screen. Okay. Okay, so let's see if we have any questions here. Alejandro corrected me. Thank you. Tier 3A and 3B are indeterminates. Thank you, Alejandro. I think tier A and F is from the UK. Thank you very much for that. So we have here a question from Dr. John Pasternak. What's the turnaround time for the report? How long does the sample take to arrive? Very good question. So from Europe, we have around 1 or 2 days for the sample to arrive in our central lab. I mean, not in central lab, but to arrive in the country. Then we need 1 or 2 days to release it from the customs in the borders, and then it arrives in the lab. And in the lab, it takes 10, 11 days. So you can consider maximum 2 weeks, something around 15 days, okay? Dr. Artur Butsovis. Sorry, Dr. Artur, if I don't speak your surname correctly. Our partner on pediatric project that we have. We are validating. Excellent talk. How about validation of molecular tests in pediatric patients? Yes, exactly what I was discussing. So thank you for that question, Arthur. We are validating the test for pediatric patients. We have a project being conducted on that. We have already tested something around 30 patients with known outcomes, but it's a still very small cohort. We didn't see any difference on those 30 patients. The negative predictive value, positive predictive value are not statistically different, but of course we need more samples, and the samples that you are separating in Poland will be really important. We will receive samples also from MD Anderson and from Australia. So we believe that in next year we'll have it available for the pediatrics. In fact, what happens is we can test for pediatrics now, but the parents need to be aware, need to agree and understand that it's a type of off-label use. So the results that we have are an estimation, right? Something that is not validated, but sometimes we receive samples from pediatric patients if they sign that they are aware about those things. Cal Singh, sorry if I speak it wrong, doctor. Is it already available in France? Yes. We have one partner in France, but we also receive samples directly. As I said, we can organize it directly with your office, your hospital, or if you want to use our partner, it's up to you. I don't know exactly the price in France, but we have a partner there. Alice, Arthur, at your disposal. Thank you very much, Arthur, for your collaboration to be here. Alessandro Serblin, what's the whole of thyroid thermal ablation therapy, such as RFA, based on genetic mutations? Really good question. A little bit polemic, but it's a really good question. So let's discuss guidelines, right? It's not yet, I will not say it's not recommended, because we don't have a guideline say don't do that. It's not yet included in the guidelines, that discussion, right? Which discussion? Molecular testing and RFA. What we have seen in real world. Remember that slide where I show you that the risk of malignancy, it's now a new risk of malignancy. So if we are in front of a Bethesda 2 risk of malignancy, maybe we could use RFA or other thermal ablation techniques. We receive samples for that, and we are also doing a study, which we already have 30, almost 40 patients. We presented also on the ITC this year, and the results that we saw comparing with Bethesda 2, we have follow-up results for 2 years. They are exactly, they're a little bit, it's not statistically significant, but they're a little bit also better than the Bethesda 2s. So many physicians are using, but again, it's also important to understand that's something really new. On the other side, when you have carcinomas, especially for microcarcinomas, we have one recommendation from Dr. Baek in one of his papers that would be good to know the status of BRAF and TERT. Because if you have both mutations, or at least TERT in isolate, maybe it's not a good idea to do RFA in that nodule due to the high probability of recurrence and best and worst prognosis. Again, something very new. Here in Brazil, in Latin America, we have doing that. for patients for RFA that will undergo molecular testing. But again, it's not being yet discussed on the guidelines. Dr. Elena De Vita, thank you, Dr. De Vita. Is there any specific preparation required for the samples? No, because when the pathologist is preparing the sample, they're not thinking on molecular tests, right? So once we use exactly the same one, they don't need to do any special preparation, right? Any preparation, I mean, in terms of any fixation method, any staining method, they're all validated. So the only thing is if they have up to 5 years. More than 5 years, it's not validated to perform the molecular test. Dr. Roberto Valcavi, my good friend, thank you to be here. So to support the view of prognostic value of mirror-type test, we had a patient with PTCM, with its a papillary microcarcinoma, with a cytological diagnosis, including second opinion, Bethesda 4. Okay, so it's a micro nodule with a Bethesda 4. The mirror-type test showed both BRAF plus microRNA 146B, which was 7,000 high, given the threshold of 200. Looking back at ultrasound images at high magnification, they showed invasion of thyroid capsule. I think it will continue in the next commentary, right? In the ATA flow chart, surgery is the only therapeutic option. Thermal ablation is not included, with a special indication for low risk micropapillary carcinoma, which are the vast majority of DTCs, 80%. Yes, Dr. Vocalvi, here, I mean, the guidelines don't bring exactly, okay, if they have this mutation or if they have that thing, what should be done. But again, a nodule that has 2 genetic alterations, BRAF mutations, plus the high expression of microRNA 146B. And it's not only a high expression, it's a really high expression. The threshold is around 200, and this patient gets 7,000. So this suggests us that this should be a more aggressive nodule. Really a big suggestion to investigate central neck lymph nodes. But again, the decision we should, as I showed you, based on the US cytology and everything. My own opinion, my personal opinion, not looking to the guidelines, I would say that it's a surgical case. I cannot say it's a total thyroidectomy. Maybe it will depend. It has another nodules on the contralobe, or maybe any other thing that would not guide to total thyroidectomy. But I mean, my own opinion would not be a nodule for RFA, or if it was in my neck, total thyroidectomy. Are the prognostic markers, Dr. Aisling O'Brien? Thank you, Dr. O'Brien, for the question. Are the prognostic markers tested only when the result is positive? Really good question. No, we test all those markers for all the patients, right? The mirror-type full has this name because we always will test both. So you can think, okay, what are the utility of the prognostic markers for a negative result? So yes, it has some utility. Why? The test has 96, 80%, right, of negative predictive value. So you can have false negatives. But if you have a false negative with prognostic markers that are negative, you can have a false negative, but you know that tumor is indolent. So even if the molecular test is wrong, the probability of that marker, of that case to evolve is much, much lower. So it's another thing that we can consider because the false negatives, they exist, just like on the Bethesda 2, right? So I think we don't have any other questions here. Carol and Gracie are saying that we'll finish here. We have time to finish that. So again, thank you everyone for being here, for your presence, for your time. Feel free to reach out to me. Here are my contacts, my email, my personal WhatsApp, and you will receive then the recording, the link for this webinar. Okay, thank you very much. See you soon.